Good afternoon and welcome everyone to this patient-focused webinar. My name is Katie Davis from Insightech, and I'm pleased to be part of today's virtual educational event. Please be patient as we take just a few minutes to allow everyone to get signed on. We'll begin our presentation here shortly. Good afternoon, everyone, and welcome to this patient-focused webinar. We're just going to give a few minutes to let everyone get signed on, and we will begin the presentation here shortly. It looks like we have a great number of attendees signed on, so let's begin. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from Dr. Krishna and Dr. Roque from University of North Carolina at Chapel Hill as they discuss what to expect on treatment day. As questions arise during the presentation, please utilize the Q&A button located at the bottom of your screen. We'll have time after the presentation to answer all questions that are asked within the chat. Let me begin by introducing you to today's presenter, Dr. Krishna and Dr. Roque. Dr. Krishna is a board-certified neurosurgeon with expertise in functional neurosurgery and neuromodulation. Dr. Krishna treats patients with movement disorders, including essential tremor, Parkinson's disease, and dystonia. He is an early adopter of focused ultrasound technology and is considered a thought leader in the field. As a surgeon scientist, he focuses on research to optimize the focused ultrasound technique to improve patient outcomes. Dr. Roque is a board-certified neurologist and movement disorder specialist with specific expertise diagnosing and treating multiple tremor syndromes. His clinical and research focus is on the improvement of tremor through both traditional and innovative methods, seeking out quality of life initiative for patients with movement disorders. He serves on multiple regional and national forums aimed at improving outcomes for tremor management. Welcome, Dr. Krishna and Dr. Roque, and thank you so much for presenting this afternoon. The floor is all yours.
Thank you, Katie. We appreciate this opportunity to connect with folks who are interested in learning more about essential tremor, learning more about focused ultrasound. So as the cadence of this webinar series goes, today's title is the treatment day. Dr. Roque, are you able to hear me okay, or any difficulties there?
Absolutely.
Great, thanks. And so we'll talk about how the treatment day looks like for someone who is undergoing focused ultrasound ablation. And before we go to the treatment day, I wanted to recap some of the aspects that we had discussed earlier in talks that were given by myself and Dr. Roque. And so the technology that we're talking about is focused ultrasound, and this is a picture of the ultrasound transducer when the cap of this transducer has been taken off to show you the under the hood internal structure of this transducer. It looks like a helmet that sits on a patient's head, and it has about 1,024 of these ultrasound emitting sources. We call these transducer elements. And each one of these elements then emits ultrasound beams that are focused in the center of this helmet. Each one of these beams by itself is harmless to the brain, but when 1,000 of these combine together at the central spot, the energy that you can achieve is enough to raise the temperature and ablate at a specific spot in the brain. And every time you deliver ultrasound, that process, that step is called sonication. And so we call that sonication and ablation. You will hear these words quite often. The ultrasound transducer, when everything is all put together, it looks something like this. This is the inside of the transducer, and it is integrated with the MRI machine Some of you have had probably the experience of having an MRI for different reasons, one reason or the other. And so ultrasound system, what involves is it has an integration of the ultrasound emitting transducer with the MRI machine. And what MRI does to ultrasound treatment is MRI allows us to measure the temperature in real time, allows us to tailor the treatment parameters that we can prescribe in a very precise way, but also allows us to do imaging of the brain. It's all about finding the right spot, staying in the right spot, and confirming that you've done what you intended to do at the right spot. And so MRI allows you to do these three things during the ultrasound treatment. Now, there are patients who come in and talk about, needing a tremor surgery, and sometimes they prefer one treatment or the other. And these are some of the common reasons that I've heard patients talk about when they talk about thinking more about focused ultrasound. It's incisionless, doesn't involve surgical incisions, implanting hardware. The effects are immediate. Patients don't need replacement of the hardware battery in the future. No need for programming the hardware in future as well. It's currently approved by the FDA for treatment of essential tremor, and you can treat both sides in essential tremor, right and left. And you have to space these treatments about 9 months apart. And the decision to do the other side is always based on the safety. And so this is the key point that I'd like to make, is that when you do think about treatment on both sides, it's one side, 9 months later, the other side, if it is safe to do that, right? And so these are key aspects. And so you'll hear a lot from our team centered around achieving this safe and effective treatments. And so that's the goal here at UNC. The second indication is tremor-dominant Parkinson's disease, then Parkinson's disease fluctuations and dyskinesias as well. These are the FDA-approved indications. And so if I were to summarize for patients with essential tremor, so patients who have been diagnosed with essential tremor have tried medications like propranolol and primidone or primidone, and the tremor symptoms, despite trying medications, are disabling, and the effectiveness of medications is not as good, or medications are resulting in side effects, and so you can't go up on the medication dose. And overall, we want to make sure that patients are medically optimized in the sense that the heart function and the lung function, all of those are in tip-top shape. Physical health is optimized, and also mental health is optimized as well. This is a stressful procedure, and so we want to make sure that your overall health is in a good state before we undertake a surgical intervention. And so with this slide, what I try to do is I try to capture all the different steps that need to happen before someone gets focused ultrasound treatment. And so all of these steps and procedures I have listed for you. Sometimes they necessarily don't have to happen in exact same way, and sometimes you can combine these steps together in order to then achieve some efficiency, depending on if the patient has some restrictions in terms of traveling and such. So the referral from your referring provider comes to UNC, and either this is from the urologist or family practice, internal medicine practices. And then we see patients, either Dr. Roque sees them or I see them, depending on what availability we have, and then get you assessed and get you information that you need to make this decision. And what we are doing also during that time is we are confirming that you have diagnosis of essential tremor. We are confirming that you have tried medications. We are confirming that your physical health is good and that this is the right treatment for you. And so that's the overall goal of that visit. Once that is done, we need to have a CT scan of the head. And some patients ask, why do you need a CT scan? The reason why we need a CT scan before the treatment is to understand whether someone's skull is favorable for the ultrasound to pass through it. Certain times, the skull anatomy is such that the ultrasound finds it very difficult to pass through the skull, and so the treatment then becomes very difficult to do. And so in that case, we want to know that ahead of time. And in some cases, rarely, if we have concern around patients, say, cognitive function, or if we become concerned that there might be some early onset of dementia and such, we want to also get neuropsychology testing. But that happens in a small fraction of patients. Once the CT scan is done, the skull looks good, then we say, okay, we want to make sure that you have the complete assessment. So, sometimes Dr. Roque has seen the patient first, and so then I see them afterwards. Sometimes I've seen the patient first, and sometimes Dr. Roque sees the patient afterwards. In some cases, when we find travel to be challenging with patients, Dr. Roque has been able to see patients on the day of the treatment as well in the morning. And so we are able to, sort of schedule these things based on a patient convenience. But I want to make sure that these are the steps when you think about the process of getting to where the focused ultrasound is done. Then you're contacted by a surgery scheduler. They discuss the different dates that are available and what's convenient to you. Sometimes, depending on patients' physical health and any medical conditions they may have, we also need to get a preoperative assessment as well. Again, that's only in some circumstances, but most of the times we get a good sense based on our assessments. This is another important part that patients ask. And so we need an MRI of the brain before we can do focused ultrasound treatment. And at UNC, the way we have organized this program is that you get the MRI of the brain at the same facility where you will have a focused ultrasound treatment in the future. And what that does for you is it allows us to acquire a very high resolution picture of the brain. That's key for us to safely do this procedure. And I'll show you a picture of how this kind of MRI looks like and what a difference it can make in our ability to deliver a safe and effective treatment. The other aspect a lot of my patients tell me is that once you go to that same facility, you also get to meet the same team. And so it's almost kind of a ahead of time, you get to see where you will be having the treatment. You get to meet the MRI folks in the break, and so it's a nice introduction before you get the treatment. And so, coming to the day of the treatment, you're not coming to a new place. You're not going to meet new members of the team, and so it's very reassuring for patients. So once the MRI is done, then we get your focused ultrasound treatment done, and we get some after the ultrasound imaging. Sometimes we do that. So first set of images is acquired right after the treatment, and the second set is acquired at 3 months after the treatment as well. And then you have your post-operative follow-ups. And this whole process can take between 1 to 2 months. And in some cases, if everything is optimized, it's scheduling more towards 1 month to 6 weeks. In some other scenarios where we have to finish some of these assessments, it's more towards 2 months, 8 weeks kind of scheduling. So that's the overall process for you to think about. So once you have gone through all of this, we come to the day before treatment. And so before the treatment, you get a call from our surgery schedulers, and they talk about, not taking, blood thinners at least 7 days prior to these interventions. And these are, blood thinners that are conventionally we are used to thinking like aspirin, Plavix, or Coumadin, but it also includes these medications that are listed here, like multivitamins, these NSAIDs, vitamin E, ibuprofen, naproxen, and such. And then nothing to eat or drink after midnight. And then you skip your tremor or Parkinson's medications 12 hours prior to surgery. We want to see your tremor in its full glory on the day of the treatment so that we know what needs to be done in order to get a relief in tremor. And so having no medication on board allows us to do a testing which helps quite a bit during this treatment. And so on the day of treatment, the first step is to do patient prep. And so what that involves is that we do a shaving of your head. And so complete shaving of the head. And what the significance of that is that sometimes air trapped inside the hair can interfere with ultrasound beams. And so that's the goal, to completely shave off the hair. And then we apply numbing medicine in 2 parts in the front and 2 parts in the back, and secure the head with what we call as a head frame. And I'll show you in a video how the head frame looks like in the next slides. Once the prep is done, the next step for us is planning. And so you are inside the MRI, we acquire a picture of your brain, and basically we are looking at the brain in real time and plan and say, okay, this is the spot we want to go after when we do the focused ultrasound ablation. And so patient prep is about 20, 30 minutes. Planning is about 10 to 15 minutes. Once that is done, there's the next step we call target verification. And this is critical step for us, in which Dr. Roque and I are constantly collaborating and figuring out whether we are in the right spot, if the patient's symptoms are improving, are they having any side effects? Because this is the time where we can adjust the spot for making the ablation. You can move it to make it safer. You can move it to make it more effective. So you can almost tailor it to your own internal anatomy. So again, we call this verification stage. That's about, again, 10, 15 minutes or so. And then the final stage is we call the treatment or the ablation stage, where we prescribe the energies that are high enough to make the ablation permanent so that you can have long-term relief in your symptoms without side effects. And so that's the overall process. So from prep to end of the treatment, that usually takes us about hour 45 minutes to 2 hours. Inside the MRI part, usually for us is 1 hour to hour 15 minutes. And so when you're laying inside the MRI and getting your treatment done. So patient preparation, planning, verification, and then treatment. So again, to re-emphasize, the entire head is shaved on the morning of surgery. We attach a frame to the patient's head, and then the space between the transducer and the head is filled with cold water. And so some patients would notice that. And we have the active participation by the patient during surgery. And so Dr. Roque is constantly testing you. We are talking about, what tremor we see, any side effects, and we are asking you questions. We are asking you to test your speech, and we are asking to see the movements of your arms and legs to make sure that things are going well in the treatment. And so that's the overall scenario. Now, this is a video. It has some technical aspects around focused ultrasound too, but this would allow you to sort of see, behind the scenes how the treatment looks like, right? And so we know that this is FDA approved to treat essential tremor and Parkinson's disease. It's an incisionless treatment, doesn't require any general anesthesia. Patients go home the same day, and the results of this treatment are immediate. And this is how the frame looks like. I talked to you about having a frame. So this is the frame. Looks like this, that allows us to keep the head steady. And important thing for you to know is that the target that we are after to improve someone's tremor is quite small. It's about 4 millimeters to 5 millimeters. And so in order to be precise at that target, you don't want the head to be moving. And so that's why we need the frame to keep the head steady. So this is in green, highlight was the head frame, and the transducer is then sitting on patient's head. And then the space between the two is filled with degassed water, and patients are then laying on the table inside the MRI environment. And we want to make sure that you're nicely padded and such and comfortable during the treatment. Now, behind the scenes, when we are planning this treatment, these are the kind of screens that Dr. Roque and I are looking at. And so this is a picture that shows the transducer in a cartoon. The colored green signifies that these elements of ultrasound are very active during the treatment. And so this allows us to create in our minds how the ablation spot will look like, and if any adjustments need to be made based on that. And then we are also looking at these numbers. And so there is a number of elements. I told you that there are about 1,024 different elements. And so, for example, in this case, out of those 1,978 were active during the treatment. Then we are looking at how much skull is available for us to do the treatment. And so it gives us a sense of the efficiency of how efficient the treatment is going to be. And then a skull score, as you can see here, I talked to you about we need a CT scan of head before the treatment. And so skull score then tells us that someone's skull is favorable for the treatment, and that we would have good outcomes in their treatment. So once we verify all these numbers, verify all these configurations, we then say, okay, let's prescribe the low energy ultrasound. Remember, we talked about this step called target verification. And so what this step involves is, let's see, And so this step involves prescribing low dose of ultrasound. And so, for example, in this case, the energy that we are prescribing is 3,000 joules. And so these are numbers. You don't have to know these numbers exactly, but this is how we think about we're going to prescribe a low energy. And then once that energy is prescribed, we are monitoring the temperature very closely. And the spot here in the center of the screen that you see, the red spot is where the ultrasound is getting delivered. And we are looking very closely and making sure that the target temperature is within the limits that we want it to be. And once you then deliver the low dose ultrasound, then you can do testing. And so low dose ultrasound just kind of temporarily stuns the tissue. And when the tissue is stunned, you then go inside and check the patient out and say, okay, can you do this movement? Let's see how your tremor looks like, how your arm moves, how does your leg move? And based on those then information, we then either keep the spot at the same place or move it. And once we ensure that it is safe to ablate, then we prescribe higher energy. For example, in this case, we prescribed the energy of 13,000 joules to make the effects permanent. And you can see that how it's a spherical looking ablation right there. And once you deliver the ablation, then patients get long-term relief in their symptoms. And as you know, over 16,000 patients worldwide have had this treatment with very good results. And it's making a huge impact in patients' quality of life. And certainly we at UNC have had a fair share of great outcomes among our patients. And so these are some of the arts that our patients created after undergoing focused ultrasound ablation. So very rewarding for patients as well as for the treating teams. So I hope with this video, you were able to then get a sense of behind the scenes how the treatment is progressing. Now, as I mentioned, the MRI that we get of the brain ahead of time, it's a high resolution MRI. And so just to orient folks, this is a MRI picture, these four different views of the brain. We are used to seeing these in orientations as if you're looking at slices through the brain while the patient is laying on the MRI table. And the gray color, this is how usually the brain looks like. It's grayish in color. And you see these dark cavities inside the brain. These are fluid spaces that allow a fluid circulation inside the brain. And so very important. And so this is all normal looking anatomy. And then on top of that, we have these different color-coded structures that are superimposed. And these structures are of prime importance for us. So for example, the structure here in pink is called the corticospinal tract. It's a technical name of a part of the brain that controls strength in patients, say, hand or the arm or leg. And so as you can imagine, we want to stay away from that area. And so we want to keep that area intact so that someone maintains the strength in their bodily, in their arm, leg, and such. The color-coded area in purple, for example, controls the sensation. And so again, this is an area that you want to stay away from. And the green is the spot that controls the tremor. And so idea is to then ablate as much as we can of that green area. And here we are showing the ablation in yellow. So this is the ablation that then is delivered to the green area while keeping it away from the pink and the purple areas in the brain. And so maintaining safety while maximizing the effectiveness of the treatment. And so that's what these MRI images allow us to do. And so again, the color-coded parts. So now what I want to do in this next part is talk to you about two patients that Dr. Roque and I treated in the recent past, and sort of go over some of the salient aspects and sort of share with you how we think about these treatments, and in these specific cases how our thinking was then influenced by how patients presented and what they really wanted out of this treatment. And so this is the first patient that Dr. Roque and I treated. 70-year-old patient who has a 20-year history of tremor. And so, Dr. Roque, when you see patients with tremor, typically you end up in seeing long histories in patients, correct?
That is absolutely correct. And in fact, as we mentioned in a previous webinar, you really want to make sure that the diagnosis is accurate with a minimum of 3 years of tremor history. So more frequently, of course, we see well over a decade, if not multiple decades, of tremor that slowly progressed or progressed in some other fashion over those decades.
And when you talk about progressing, is it progression, year over year, or do we see more like a 3 to 5 year or 10-year time frame?
So that is really all over the map, and this is something we understand. Well, we actually don't understand enough about what are the variables that play a role in the severity of that progression, where some folks can have disability develop over 1 to 2 years. We can have folks who develop disability, the same level of disability from their tremor over 30 years. And in fact, those often influence, right? You can imagine whether folks decide they want to move forward with procedures, because a sudden development of worsening tremor often is associated with a sense that you've never had an opportunity to compensate for that tremor.
Makes sense, makes sense. And so if the progression has been happening over a longer time, then we are able to sort of take that challenge and sort of work through that. That makes sense. And often we see that patients have some family member who has history of tremor as well. For example, for this patient, their mother and grandmother had tremor. And this is another aspect, Dr. Roque, about alcohol responsiveness. How often do you see this, and what do you make of this?
So, if I'm being honest, I have stopped asking this question of most of my patients. And the main reason is because it is another scenario of all over the map. This doesn't define your tremor. This is an important piece of this. There are those out there who may have been told that, well, it's not essential tremor because it doesn't respond to alcohol. And I couldn't more strongly advocate against that comment, right? That in fact, some folks just respond and some folks don't. And the impact is pretty small, just because we certainly wouldn't want to start advocating for anyone to drinking regularly in the scenario to try and improve their tremor. But historically, if you talk about, I'll go back to the family history point. We do see a family history sometimes of alcoholism in patients who have tremor, where the best thing we can uncover there is perhaps that's what family members, decades ago learned to utilize to cope or compensate for their severe tremor. So that's probably the one piece of information that can be helpful to put all this together.
That's great. And so just to re-emphasize that if alcohol doesn't improve your tremor, that doesn't mean that you don't have essential tremor. And so something folks to keep in mind. And so this patient had their hand tremor treated in 2020 with excellent results. And now they represented thinking about treatment for the left side tremor. And when we talked to the patient, they said, that they're having difficulty doing activities that require you to use both their hands. For example, eating food, buttoning the shirt and typing, which was important for their profession. And then playing music, that was the other piece that this patient played guitar and was finding it difficult. Even though the right side was treated, they still had tremor in the left side and needed some help in that. They could take medications, PRN, Valium. What are your thoughts around this idea, Dr. Roque, that sometimes some of these medications that help with anxiety too can help with tremors as well?
It's a great question, and it's a double-edged sword in many respects. First is drugs like Valium in that whole category are taking advantage of the same pathway as alcohol. So not surprisingly, if someone has responsiveness to alcohol, you'll find the same. In fact, if anything, it's a bit more potent. And you always have to be concerned about interactions should you choose to drink simultaneously when using this. It would be recommended against. But there's one other piece to this, which is that, and perhaps this is where alcohol actually plays a role, where we know anxiety absolutely enhances tremor. This is among the many stressors that worsen tremor. So we are not surprised to hear stories when anxiety is successfully reduced that tremor amplitude follows suit. Doesn't disappear necessarily unless you're early on with your tremor history, but at least improves it to a more manageable level for a short while.
That's great. That's great. And again, we want to emphasize this patient when we examine them did not have any imbalance or swallowing difficulty. So these are the kind of things that we very carefully observe the patients for and ask history to make sure they're not having these difficulties. And so as we approach this patient, the goal was to help with the left side tremor and potentially help them get back to playing music again. And so this is how the what we monitor, and this is where the crux of a lot of the activities that we do here at UNC comes into picture, is collaboration between the two of us to really understand that we get the maximum relief, but then avoid side effects. And so the table on the left-hand side shows you the tremor scores that Dr. Roque has been monitoring. And so I can have Dr. Roque go over some of these scores. Dr. Roque, how do you explain these, and what should we make out of these scores?
Oh, it's a great question. And the short of this is these are 4-point scales. So 4 is the higher end. And as you can tell from some of these, we can actually score these in halves in order to create more of a gradient. So a sense of, the severity over a spectrum that is not a perfect spectrum, but it certainly just makes it a little easier for us to compare one person within themselves. So what I mean is, this is less about comparing one person to the next person with tremor. It's really just meant to show the changes and differences you can have from moment to moment. And the utility here is really during the procedure, and I'm only going to talk about the tremor scores for a moment. We can really give ourselves a sense of the percent improvement that we can see very objectively. Now, it does turn out, very important caveat is that these objective scores really don't match up terribly well with a person's perceived benefits from this procedure. And the same could be said in terms of the inverse, right? If this tremor score gets worse for any particular reason, folks don't necessarily see that as the same degree of worsening of tremor as we do objectively. But nonetheless, it's a degree problem, not a direction problem, right? So if it's worse, it's worse. If it's better, it's better. But at the end of the day, it's the best we have, shy of just listening to you as an individual telling us the changes you're experiencing. And often what we quote when we talk about percent benefits from each of these procedures is with regards to the objective scores. So if you were to have an objective score of 70%, but you perceive an 80%, we're not going to sit and argue with you. You perceived an 80% improvement. But objectively, we see this change. So the numbers we quote usually are on the order of the objective changes.
That's great. And so we are constantly monitoring these objective scores. And as you can see that, some of the scores, say, for example, arm extension, 3 out of 4 is quite significant tremor. Wing beating, again, is the same. So these are different types of tremor. And we're trying to get a sense of where exactly the tremor is localized. And then we also monitor for side effects. Dr. Roque, can you talk about this last row here that talks about side effect rating as well?
Yeah. And so there are different, just even thinking back to the screen that Dr. Krishna showed, where there was these different sections and areas of the brain responsible for different levels of function. Each of those effectively has a scale score we can use to define, once again, as objectively as we can, a sense of difficulty or impairment that we might be developing or creating as a result of being in the wrong space, right? So even if we sonicate, we just heat things up, we don't burn yet, but we're in the wrong space, we might see some of those changes. Our goal is to keep this number the same, if not better, but not because we made something truly better there. The tremor might have been intruding on another objective score. And so we're trying to keep this number the same from before surgery to after surgery, so that we're not creating new disability as a result of trying to improve the tremor.
That's great. So in this case, as you can see, the summary slide, the tremor score reduced from 16 before surgery to 6 afterwards, while the side effect score remained the same. As Dr. Roque mentioned, that's the goal, to keep the score steady. And we were able to achieve this with a total of 4 sonications, out of which 2 were ablation. And so treatment time was about an hour for this patient. So this is a video of the patient that they recorded for us, and I'd love for you to hear on this. And Katie, I hope people are able to hear this because I have the volume on all the way up on my side. And so if there is any issue, let me know, okay?
Probably the most emotionally compelling thing for me was that I was able to play the guitar. And I had not done that in years. My wife, who I've known now for about 14 years, had never heard me play the guitar. First thing I did, grabbed a guitar and played. And it's like, my gosh, I'm playing like I'm 25. Yelled to my wife, said, come here. And I was just so excited. I mean, even now it's still causing some chills. There are like tears coming down my eyes. And I started playing a song. And I played other songs. And it was like just such a magical moment of restoration, of, like I said, of having my life back.
That's great. So let me take you
Probably
through
mostly.
another patient history. And again, we'll sort of go through some of this history. As you heard, 70-year-old patient with a 20-year history of tremor again. And she again experienced tremor that was worsening over time, had a family history of tremor. And this patient was left-hand dominant, and we treated this tremor back in 2021. And then the patient represented but that some of the same things that use both hands, she was finding it difficult to do, like eating food, buttoning shirt, putting on jewelry and makeup. But then the other aspect that this patient highlighted was playing golf. She learned playing golf from her father, who had to actually give up playing golf because of his tremors. And so she came back and said, I don't want to do that again. And I hope that you're able to help me and help me continue to play golf. Again, this patient was not taking any medications, but if you pay attention, had some difficulty with balance and some difficulty with swallowing, especially liquids. And so those were the signs that we wanted to keep in our mind that this patient has to begin with, and we want to make sure that we don't make these worse. And so that's our goal. So we very carefully assess your symptoms and really individualize this treatment for you. And so I'll have Dr. Roque talk about some of these scores again and the side effect for this patient.
Yeah, so I appreciate it because this one's tricky. If you notice, there's a lot of there's aspects of this where a lot of scores may look similar at first glance or may not look as dramatic as our first case. And truly, when you do the numbers, right, we still have a tremor score that's at 10, where we didn't quite get to 50% objectively. You'll see in a moment because Dr. Krishna will walk through how the patient perceives this. But a lot of this was from the fact that we were appreciating changes inside of the procedure in terms of balance and speech issues. And the speech issues sometimes do correlate well with swallowing difficulties. And so we already started with difficulties before we walked into the scanner. And here we are just experiencing changes on the table before we've actually burnt anything. So we're trying our best to navigate around that, being cautious, being conscientious, and ultimately creating, if you see here, we're lowering the temperature overall in an effort to minimize the risk, make the lesion smaller, do it over perhaps a few additional, right? So instead of 2, you see 3 ablations here, 5 sonications. But we're really taking our time to do this carefully, thoughtfully, to get even at least this much tremor reduction, and then make that. And honestly, one of the things we do in these scenarios where someone walks in, even if I'm meeting folks for the first time the morning of, we come together to a decision, an important decision, a safety metric, right? So to talk to each other about what is good enough to say that this was worth it without starting to induce side effects, right? Because sure, maybe we could have gotten better scores, but at what risk? And to what point of these side effects? So really, yeah, this became an important conversation for this person. This person was going to be happy with at least reducing about 40% once we kind of came to those agreements, and effectively that's what we hit objectively, although she will tell you differently when push comes to shove.
Yeah, so absolutely. So in this patient, we were able to reduce tremor by 45%. And as you can see, the side effect score remains the same. So again, that's a key aspect for us. And we kept, temperatures and such in a way that we reduced the risk of side effects. And this is a picture for the patient that they sent us playing golf and enjoying life and really happy with their tremor outcomes. And so that's the crux of doing these treatments in a methodical way, thinking about what patients' goals are. And at the end of the day, we are here to help support you, support your decision making. And so that's what we are here for and to support you in this. Now, going into the post-op aspects in the last few minutes. And so some activities that we want you to restrict, we want you to rest and relax for the first 2 weeks after surgery. We don't want you to be doing no more than, light housework, just very, very little activities. And then for the first 4 weeks, do not engage any heavy activities. Do not drive for the first 4 weeks, and then slowly increase your activities after 2 weeks of surgery. And this is just to avoid getting into a situation that you're bending over to pick something up, and next thing you know, you lose balance and tumble and hit your head and these kind of things. And so idea is to take it slow and then slowly start moving activities 2 weeks after the treatment. That doesn't mean that you can do these things. You're not having any active pain, but always better to be careful. Expectations overall 60 to 70% reduction in tremor. And then risk that we worry about sometimes is impaired balance. We call this ataxia, especially if it has existed before surgery. As Dr. Roque mentioned, difficulty with speech, sometimes we call this dysarthria, swallowing difficulties. And then the other important aspect I'd like to highlight is patients have had this tremor for decades. And so sometimes we then come up with adaptations around this, like Dr. Roque mentioned in the beginning of the talk. And what that practically means is sometimes if you're having tremor in the dominant hand, you start to learn to use your non-dominant hand, left hand. And then after the treatment, sometimes you have to relearn or sort of trust your dominant hand to start doing those activities again. And so something to keep in mind. And so overall, there are certain situations where patients can have delay. We talked about this timeline of 1 to 2 months. If you have medical conditions like uncontrolled blood pressure or diabetes, the body habitus is critical because the table for focused ultrasound that we have doesn't allow treatment for more than 290 pounds patient's weight. Skull density, we talked about, some skulls are unfavorable. If patients have MR incompatible pacemakers or other devices that are not compatible with MRI, that's again, can't do these treatments. Or if there are situations where patients can't stop the blood thinners, then that can become a difficulty. Then again, challenges with social support, mental health challenges, patients who are active smokers or who have bleeding risk. Then again, some of these things can delay or even prevent surgery. And this is the last slide I have, and this is our team here at UNC Chapel Hill. You saw and talked to us too, Dr. Roque, myself. We have other team members. You see in the bottom picture, Wes, who is our coordinator on the neurology side, and Kelsey is coordinator on surgery side. I would include her picture next time. And team members from research and occupational therapy in our tremor interdisciplinary clinic. And so I'll leave it at that, and happy to take questions after this. I'll stop sharing.
Awesome. Actually, can we leave that last slide up? So if
Okay. Very
would
good.
like to take it and didn't take a picture that fast, that they can still see it. Okay, perfect. And so if you have questions, thank you guys both so much. I learn every time I hear this talk, even though I've heard it, I learn something new every single time. So I really appreciate you taking the time to talk to all of us. We do have some questions queued up. If you have a question, feel free to get it in the Q&A and we'll get going here. So if a patient is inside the MRI, how do you, for example, write your name? So this is a great question to hear, and like you to kind of walk them through how they would do those type of texting if they're in the MRI.
Sure. So what I'm doing with our patients in the MRI scanner, we have a clipboard, and the clipboard has no metal pieces to it because we have to be metal free inside of the MRI suite. And then we have very minimalistic pens that we have also found can write upside down. They're not quite the zero gravity pens that are out there, but at the same time, it still gets the job done for you to be able to apply enough pressure to the clipboard to be able to write what we're asking you to do. Same thing goes with performing spirals. You'll be doing those effectively, in a sense, upside down, or rather just because you're laying on the table. So imagine just having to push up against a subject instead of, just naturally coming down onto a desk.
And then can we talk about how much of their body is in there so that you're not passing a little clipboard through an MR and maybe I'm like this trying to write for you. So maybe that could be another part of this question that they're not quite
No,
understanding.
that's perfect. I appreciate you asking this because we certainly, for purposes of performing the heating process and for getting scans, you need to be into the, all the way into the scanner effectively. Feet will be out, but for all intents and purposes, into the scanner. Then for all the testing, we are pulling you fully out of the scanner to perform that testing. So there is no reaching into the tunnel. You are completely out of the scanner for all the testing opportunities. Because as you can kind of see just through, even just through the tables that Dr. Krishna showed you today, that's only about a third of all the testing that's done with every one of these sonications. The rest is lumped into that side effect category, but in truth, that's about another 2/3 of processes that we need to take care of and assess carefully every time.
Can I say something here, Katie?
Yes.
Dr. Roque is the master of coming up with these tests to figure out if patients are having side effects. In fact, in the last 6 weeks or so, we introduced another testing, right, to get a sort of indirect measurement of your coordination so that you can predict balance. Dr. Roque, you want to talk about that?
Yes, no. So what we've added recently, we were already using for your arm, for your face, for your voice measures of coordination, but at first we were a little concerned about moving the head if we were moving the leg too much, but it actually turns out that we could do that quite safely without moving the head. And so now we started adding leg movement for coordination testing. It's again, you have to be out of the scanner for this, and plenty out of the scanner for that purpose. But it seems to correlate reasonably well with if we're going to develop some difficulties with balance. So we're very carefully assessing that. It's been perhaps particularly helpful and useful to minimize that risk for us. I feel like we've heard fewer instances since we've used that information. We've had fewer instances of folks complaining of any significant balance difficulties after this procedure.
That's great.
I love that. And I love that you guys are constantly looking for ways to improve. That's mark of an amazing team. So this next question, I'm going to read it verbatim, but let's maybe talk about what this person means. And if we don't get it right, please correct us in the Q&A. So what scarring does the focus ultrasound energy produce? For example, if it's slightly off target. So
yeah,
what kind of scarring, what kind of adverse events, what kind of long-term can we expect to happen?
That's a great question. And so one way of thinking about this is that the effect of ultrasound on tissue is dependent on how much dose of ultrasound you prescribe or you deliver. And so if you prescribe above a certain threshold, then you have what we call necrosis of the tissue. What that means is that you have permanently ablated the tissue, you have burned that tissue. Then there is a dose, below which, if you stay below that, you can temporarily stun the tissue for, sometimes 4 to 5 minutes, sometimes 5 to 10 minutes, sometimes to a few days to a week. And so that's, again, a very small dose that can stun the tissue temporarily. And everything in between is we call partial ablation, meaning thereby that some of it is disturbed and some of it is ablated. but then the brain has the capacity sometimes to heal around that. And so those are the terms we are used to thinking. And so if we are not careful and you end up in ablating, adjacent to where the ablation should be, then certainly, patients can get side effects. And some of these side effects, we talked about that, difficulty, say, in strength in arm, strength in leg. Coordination is the one that we worry the most about. It's the one that we see also related to, ablation, but more commonly related to swelling. Once you have done the ablation, for the first few weeks, there is swelling around the ablated site. And so you can see some of these side effects just from the swelling. And as the swelling gets better, things get better, they improve. And so if you think about the overall risk of side effects, I would say that in about 1 in 5 patients, you see some kind of side effect that could appear because of the swelling in the first few weeks. And as the swelling gets better, then that risk of side effects gets better. And to the point about off-target ablation, that's where there is a critical role of getting imaging and really mapping out exactly where we need to go before the treatment.
Awesome. The next one is acupuncture a viable treatment for hand tremor? And if so, is it treating the hand itself or the head? Can we talk about let's talk about acupuncture. Let's talk about Botox. Let's talk about, there's another question here about the effectiveness of Calitrio. So leading up to maybe a little bit before doing an intervention, maybe Dr. Roque and Dr. Krishna, if you can talk about all those other options that might be explored.
Sure. This is a series of loaded questions that can have their own hour apiece, but I'll try to summarize it within a minute. Acupuncture, like a lot of complementary alternative medicine, has a lot of place for a lot of different sets of symptoms. And there's a lot of information when it comes to Eastern medicine pursuits where you just have to understand that perception of the human body and how to otherwise improve upon symptomatology through that understanding, through that base core understanding, which is my way of also explaining that through mechanisms that are harder to explain here because we're not talking through allopathic medicine, folks do see improvements. The degree of that may be related to underlying anxieties, may not be related to underlying anxieties being managed through these interventions. How well does it work? It's the verdict is out. I certainly have patients who supplement their overall care with things like acupuncture to try and to assist. Because it was a mention and comment there about head tremor. So head tremor is an interesting and important distinguishing feature here. So with essential tremor, if you go to a couple of talks back, we mentioned how the head tremor certainly can be a symptom of essential tremor, but can also be related to other conditions that can come with essential tremor. And the main condition that comes to mind is cervical dystonia. Cervical dystonia, the primary process seems to be that your brain is sending a signal to the muscles of the neck, asking it to hold a posture that you are otherwise fighting, and that can create this very jerky appearance to a head tremor. And if you instead injected with Botox, you injected muscles that were causing the posture, you can weaken those muscles just enough, in theory, just enough so that the signal doesn't come through reliably. The extra signal from the brain doesn't come through reliably, and so you have less head tremor. The theory doesn't pan out as well with essential tremor, especially not with head tremor from essential tremor. But nonetheless, some folks try it to see if it makes a difference or makes a dent. With the arms, Botox therapy the verdict is still out. People have been trying to use it for upwards of 30 years with varying degrees of success. And there is one major study that is coming to a close to hopefully finally answer that question for us in the next 6 months, once all the analysis is done of that data. And the Calitrio is an interesting entry into all this. This is just a method to wear a watch that stimulates your nerves out in the forearm, more specifically close to the wrist. And what you're trying to do there is, in theory, stimulate those nerves. The theory is that we are somehow affecting the signal coming from the brain that causes a tremor in the first place, and that leads to a change in the tremor. The most notable change that is documented about Calitrio is that if you have severe tremor, this is the group of folks who, again, objectively have severe tremor, objectively see a change. But I will tell you from personal experience, but even that's been pretty well published, is that it doesn't, remember I mentioned earlier that we don't see the same correlation between objective changes and subjective changes. So we may see an objective change, but it's not frequently associated with a subjective change from folks who went through the process, where the Calitrio itself gives you about an hour and a half's worth of benefit on tremor for every 45 minutes that you sit doing stimulation. So a change, yes, objectively more so than subjectively, and really for folks who have more severe tremor, perhaps, than for folks who have milder tremor.
Awesome. Thank you for the fact that I gave you 20 loaded questions. I knew what I was doing, and you did a great job with that. So we hear this a lot. So what are the results with focus ultrasound when it comes to your voice tremor? And maybe I know we just briefly talked about head tremor or an internal tremor, all of those other things that we sometimes hear people ask about besides our, hands.
So I can comment on so we call these areas of tremor midline tremor or axial tremor. So this includes the voice, the head, the neck, the trunk for that matter, right? So your core as opposed to your upper or lower limbs. Axial or midline tremor might benefit from focus ultrasound, and I'll preface it exactly that way because there is when you look at direct data, no one's really been specifically measuring those areas of tremor as a primary reason to pursue focus ultrasound. Instead, it's you're undergoing focus ultrasound to help the arm or hand tremor, and then you're measuring the change in those midline tremors simultaneously. This is an important nuance because we do have, so by doing a single side, we pretty close to, and not never, but pretty close to never see a real change in those midline tremors. However, when you do the second side, verdict's out, but with the recent study allowing us to go to the second side for essential tremor, there have been some folks that seem to appreciate a difference or a change. I think this change is most appreciated immediately after the procedure, and we've certainly seen that immediately after the procedure it's there. But the sustainability of the midline tremor control is what comes into question after focus ultrasound. And that's where the verdict is still out. We probably need much more data to parse through that before we come to any meaningful conclusion, right? So I think the short of this is I wouldn't necessarily go into focus ultrasound specifically to address your midline tremors.
Perfect. That is great. So this next person, this is another loaded question for you, Dr. Roque. I am so sorry. So they were recently diagnosed with essential tremor. What is the difference between a Parkinson's diagnosis and an ET diagnosis?
So maybe this will be a great opportunity for me to just put a small plug for, please go look at our YouTube pages. We do have a lot of these talks up with much more detail than I could give to an answer right now. So by all means, I'm just going to invite you to do that. But simultaneously, so the question is predominantly how do you differentiate between the two of them? You want to have someone who is well-trained in understanding tremor syndromes. Movement disorder specialists as a group are a group that are very good, where we are specifically trained at trying to differentiate these tremors to the best degree possible. The caveat, though, is that you can have overlap of the two tremor types from both conditions in a single condition. So you really need a lot more than just looking at the tremor alone to help distinguish between two conditions. That said, the treatment for the two tremor types is actually different, and that includes medications that you might choose. to try and make the tremors, each of the tremor types better. As well as the way we target for focus ultrasound, or even for the way we target for deep brain stimulation surgery. These are the locations where tremor seems to move through is not precisely the same for both conditions. So that's an important point there.
And even because I know I've learned this from you, so I'm going to tee this up here. Even if for some reason someone's diagnosed with essential tremor, does that preclude them to maybe doing a Parkinson? Can sometimes tremor, even if you're a Parkinson's patient, come up first? And I know patients sometimes say, did my essential tremor evolve into Parkinson, or because I had that, it caused my Parkinson's? Can you kind of talk about that journey and the things that you do at UNC to ensure that you have that proper diagnosis for these patients to do the best kind of modality for them?
Yeah, I see what you're getting at, and so I'll try to put that all together into a response, which is that in essential tremor, we know there is an increased risk of developing Parkinson's. And that means that you could have both conditions. That risk is not a high risk. So it goes from the general population where folks have a less than 1% chance of getting Parkinson's to a roughly 5% chance of getting Parkinson's if you also have if you already have essential tremor. And that's a lifelong risk as far as we know. It's and that's as far as we know, because it is hard to parse this data out. It is the reason why I tell folks with essential tremor, you may not see a physician quite regularly, but having an annual visit with a neurologist and maybe arguably with a movement disorder specialist where you can it is quite helpful, just to make sure we're not missing those early signs, to try and advise you on things you can do to slow things down, to perhaps perform more cardio exercise, maybe even pursue a better explanation for symptoms that are vague but are related to evolving Parkinsonism. What we do here, we have a couple of scenarios. I mean, you're seeing on the screen the Tremor Interdisciplinary Clinic, which is really this consultative model where we work with your healthcare team to give them meaningful information on how to parse out your tremor syndrome, what it's related to, are there any additional signs or symptoms. It certainly involves visits from each and every one of us here you see on the screen, and we work to provide a pretty comprehensive degree of information for your healthcare team, so that they might be able to locally assist you with improving your tremor and improving your quality of life through the recommendations we provide. And so it all starts with the right label and the right diagnosis. Otherwise, we can kind of end up in a lot of sort of wrong avenues of treatment options if we don't have that correct label to start. So we're happy to help where we can, certainly in this team. So
Awesome. Well, that seems to wrap up our questions right now. If for some reason you think of something after the fact, feel free to reach out. Happy to answer those. On behalf of Insight Tech, Dr. Roque, Dr. Krishna, thank you so much for taking the time this afternoon and talking with us, answering the questions. For everyone that signed on, thank you for spending your Monday afternoon with us, engaged and giving us questions and allowing us to be part of your educational journey with essential tremor and Parkinson's disease. Everyone have a great afternoon.
Thank you.